Alrighty, hi everyone. Thank you for joining us today for our Advocacy and Diversity webinar titled Bridging the Digital Divide in the Community Towards Health Equity.
Tony, could you let me share my screen?
Hang on a second. Okay.
Perfect.
So this webinar will discuss health equity and its sustainability beyond the global pandemic. Experts will share their narratives on how the global pandemic pushed to remove barriers with access to care, address interoperability, and legislations that impact consumers. We will explore how we can address and offer solutions in delivering fair and equitable digital healthcare through research, innovation, and advocacy. It is my honor to introduce our esteemed panelists, with the first being Dr. Andrew Goodwin. Dr. Andrew Goodwin is a practicing board-certified family physician and a site medical director at Callen-Lorde Community Health Center, a federally qualified health center caring for New York City's underserved LGBTQ community. As part of primary care, Dr. Goodwin integrates HIV management and hormone therapy for transgender patients, including minors and their families, into his practice. Additionally, he serves as the provider champion on Callen-Lorde's Health Information Technology Governance Committee and has worked on projects involving process improvement, telehealth implementation, and electronic health record migration. Dr. Goodwin completed his medical degree at Wayne State University in Detroit, Michigan, and his residency at the University of Pennsylvania Health System. He is also currently working on a master's in population health informatics at the City University of New York's School of Public Health. We also have joining us Ian Slade, who is a healthcare innovator and advocate. He is passionate about finding ways to do things better, faster, and cheaper without compromising patient outcomes. From the patient bedside to the halls of Capitol Hill, he has advocated for the betterment of patients, clinicians, and the industry as a whole. He is currently the managing partner of INT Consulting Group, LLC, a healthcare-focused solutions firm located in Southern California. He also teaches the Project Management Professional Bootcamp and the Physician Informatics Fellowship at UCLA Health. Most recently, he was selected as the 2022 HIMSS Advocate of the Year, and he was awarded the Healthcare Visionary Award by Health 2.0 in Dubai. We also have joining us Dr. Carolyn Sun. Dr. Carolyn Sun is an assistant professor at Hunter College in the School of Nursing. She also holds an adjunct faculty position at Columbia University School of Nursing and is a nurse scientist at New York Presbyterian Weill Cornell. She also serves as the co-chair of the Digital Communications Community for the American Medical Informatics Association Nursing Informatics Working Group. Dr. Sun's research is focused on the use of technology to improve nursing practice and patient outcomes, with a particular interest in how to reduce disparities in healthcare through the use of artificial intelligence. And last but not least, we have Joe Zaccaria. Joe Zaccaria joined Nitira in January of 2018 as a Director of Strategic Relations and is based in the New York City area. Joe is responsible for channel partner relationships, business development, and investor relations activity in the Americas. Prior to Nitira, Joe spent about 8 years on Wall Street covering technology companies as an investment analyst. I'm going to hand it over now to our amazing moderators, Alexis Balancongan and Dr. Rosemary Ventura. Thank you.
Thank you so much, Christina Chan, and thank you so much, and welcome to our audience. And again, thank you to our esteemed panelists for joining us today. So this question is for everyone, but we'll begin with Dr. Goodwin. So how are health, social, and economic resources allocated in your community today?
Yeah, thank you for that question. And in thinking about that one, there are so many ways to answer that question about how resources are allocated. And would say where I work, kind of in the FQHC environment, we really try to work very hard against a lot of the social forces that I think favor certain communities in receiving these resources, but we still see how race, ethnicity, sex, gender identity, sexual orientation affects who gets access to those resources, and in particular, how all of those identities really intersect and affect ways that people have access to those resources. But I think what is interesting with our kind of FQHC model and infrastructure is in many ways, I think we are able to bring a lot of resources to the folks who have been historically marginalized and left out. That in many ways, you know, we can make up where we can for a lot of those social forces. And sometimes I think it's even for the folks who are kind of in the middle. You know, when we think about access to healthcare resources that probably struggle in many ways that we don't think about. If, for instance, they're buying an ACA plan for their healthcare coverage, they have a high amount of cost sharing. Sometimes those are the folks that we have the most difficulty helping with access to health, social, and economic resources. But it's really a great question, and I think a complex one.
Absolutely. Sometimes it's the socioeconomic barriers that we have to, that are very challenging, and how do we provide, you know, to our community to gain that access? Absolutely. And Dr. Sun, what about you in terms of, you know, access, and how are those allocated within your community? Oh, sorry. Dr. Sun, you just have to go off mute.
Sorry about that. Sorry. Does Tony want to put up the slide deck for me?
Oh, sure. We were just asking if, you know, in terms of, you know, how our, let's say, access to care or socioeconomic resources are allocated to you, and then Tony has your slides up.
Yeah. So I was just going to do an overview of the bias in U.S. healthcare, just as like a starting point. We know that there have been racial health disparities in the United States. And these, and I think this is maybe the second slide, but anyway, the point, yeah, okay. So there have been the existence of racial health disparities across all social domains over the last 50 years. And these have had associated harmful social and health outcomes and a lack of institutional investment. And part of critical race theory, which I know some people really hate to hear that term, but part of it is this idea of interest convergence, where these are things that are never going to be corrected until it really affects the primary race. So the idea is that now that we realize that these are causing these implications in healthcare that are costing $363 billion, that now we're more interested and invested in reducing social disparities. So if you go to the next slide, we see that this is something that is come up in medicine through the NIH initiative Unite, the nursing, the future of nursing, and within public health as well. And so there are these structural determinants of health that we need to address in order to reduce these disparities. They've been identified as a direct cause of health disparities by the World Health Organization, and they are defined as all mechanisms that generate and define individual socioeconomic positions within hierarchy and power and access to resources. And structural determinants of health have a downstream effect on health, creating disparities. So the next slide. And again, this is part of this idea of like structural racism. So like certain, the way that things are set up are beneficial for certain races over other races. And so this is beyond the scope of this, but just to understand that it's embedded in the laws and policies and institutions and provides advantages to the dominant racial group while oppressing or disadvantaging other groups. And there are two critical elements, a set of processes that generate disparities, and then there's also the idea that it reinforces and perpetuates racial group inequities. And then, so within healthcare, I think like the big idea is that we have these, this like culminating and perpetuating system of these biases and inequities. And the area that I'm interested in and that I do research in has to do with technology and artificial intelligence, and the idea that, you know, like we have clinical decision support models. So for example, like if a nurse or a physician or a nurse practitioner goes to give a certain medication, they're given these certain alerts, right? And the alerts are generated by artificial intelligence. And those may be developed in a way that's a fair artificial intelligence model, but depending on the way that they're received, they may not continue to be fair. They may have latent biases, such as adaptive learning, which is where, like, if depending on the way that the data is received, it could change over time. There's clinical implementation, which is like if the physician or the nurse practitioner or the nurse ignores or responds without thinking about what it really means. Those are also biases. And then the way that we evaluate the outcomes could be based on some biases within us that are not dependent on the actual outcomes that are meaningful to the end user. So next slide. So these, there have been a lot of criticisms of artificial intelligence and machine learning based on these things. The intrinsic biases based on the people who are developing that technology, the data set inaccuracy, which could be, you know, if we're just basing it on, like, historically, I think a lot of our data sets are based on white males versus other groups for whatever reason, which is the same as under and overrepresented populations. There are ethical issues today and in the future. There's a lack of standardized best evidence approach or guideline for model assessments. So just even the artificial intelligence that we already have, we don't have great ways to like evaluate whether or not they're working or whether they're appropriate. There's a lack of transparency in inputs and outputs for predictions or outcomes. So next slide. So as I showed in that other model, which, you know, came from colleagues that are much smarter than me, these models can become biased over time. We're using these algorithms and bias settings. For example, like where I work, I'm a nurse scientist at Weill Cornell. It's on the Upper East Side. So we have a very specific patient population that may not be representative of all populations in the United States. And so if clinicians always follow the suggestions, or I would say even if they never follow the suggestions based on these clinical decision support, you can affect the way that your algorithm develops over time. And the privilege bias is disproportionately benefiting individuals who already experience privilege. So I think like, well, Cornell might be a good example of that. Like, we're developing AI with the smartest people in the best, you know, neighborhood and all of that for the people who already are very privileged anyway. And the goal and the outcome measure can be biased. So it can, like, for example, maybe you're only helping this certain group of people that you're representing. So there are also risk correction algorithms, but sometimes these have a lack of rationale from the people who develop them, and they're based on old and outdated science, or they're colorblind, which really doesn't make sense because we don't need to be colorblind. We need to be accurate about who we're talking about. So one example is this, the next slide, the heart failure risk assessment. It assigns 3 points, so it like intentionally puts Black people at a higher risk than non-Black people, so they end up in disproportionately treated or undertreated versus their white counterparts. And that's just like one example. I think there are actually more powerful examples in kidney failure, maternal mortality, and other cases. But this is just one. So some of the ways we can treat this is to treat it as a patient safety issue. We can regulate, we can implement a regulation that specifically monitors for biases. So that is something I think that the US government is currently working on. Engage stakeholders in the design and implementation of artificial intelligence. We can increase the diversity of the tech workforce. We can design our artificial intelligence to include more diverse people. And we can train our systems with better data that include all kinds of people. And we can give bots a variety of voices. So that would be like speaking to people in the language that they understand. This is a model that is the fairness, accountability, and transparency and algorithmic affordance, the FAT conceptual model. So just looking at data and artificial intelligence in healthcare in all of these different aspects. So I think that's all. Thanks for listening. Hope that wasn't too much information.
Oh, not at all, Dr. Sun. This is amazing. I know that in 2 slides back, you had mentioned, giving bots a voice, in terms of like, what are some, ways we can improve. But how do you think, other than the ones you listed, or, you can speak to some of these a little more in depth, how do you think we can better bridge this digital divide so that we can ultimately improve the outcomes, of our delivery of this digital healthcare space?
I don't want to like take over. But I do want to say, like, the way that giving the bots a variety of voices is really important. I think, especially because the way that we speak to people really matters, right? Like, not everybody is a trained healthcare professional, and our vernacular is very particular, so it can be really difficult for the average lay person to understand what in the world we're talking about half the time. So I think if we could do that, that would be a huge part of just making things more understandable to the average person. I don't know. I think other people probably, sure, other speakers on the panel have more to say about that.
Absolutely. And I know Dr. Ventura has some questions next for Joe Zaccaria. So it's a great segue from your research. And now we'll dive into some of our solutions that we have that can enable this.
Thank you, Alexis. I do actually. So welcome, Joe. I hope you can all hear me, I think. One question that we did have for you is, how does Nitira support health equity initiatives in healthcare today. Maybe we could just give us some sense of what that is.
Yeah, sure. So I appreciate you having me on. Can everybody hear me okay?
Yes.
All right, great. So I have a couple of slides I'll run through, but I think this one, I'm happy to just sort of answer off the cuff. What we noticed when we started our company, just some background, we provide a vital sign monitoring tool based on a sensor that we developed that allows us to measure vital signs without the need for a caregiver, someone to remove clothing. It doesn't matter your skin color, your gender, your ethnicity, your sexual orientation. All you need is a pulse and the ability to breathe, and we can monitor you. And our company is based in Israel, and there's a lot of some of the similarities that we've been facing in Israel with different races and different religions and different sects and privileges and people who are disproportionately impacted by the financial status that they might have or whatever religion they are. We thought that there was a better way to connect them. I mean, we can charge our phones wirelessly today, but you go to a doctor's office and you have to take your shirt off and you have to put a skin patch on, or you have to wear something, or you live in a rural area and you don't have access to leading doctors. Our view is that technology can bridge all of these gaps, and Dr. Sun talked about bridging the digital divide. We have a saying, in our company, that we bridge the analog to digital divide, the analog being the human and the digital being all of the amazing things we can do with technology. There's just not that gap there to make it seamless. So what we did was we built this platform to actually enable that connectivity of patients who are in underprivileged areas but have complex cases, who want to meet with leading doctors at Weill Cornell, who don't have them, who can't get there, who are uncomfortable taking their clothes off, who just need somebody to connect with them in a manner that they are comfortable with. And that was really our entire initiative of doing this. So that's what we're doing. We do a lot of this in long-term care. We do a lot of this in rural America. Our intent was to bring the cost down enough that a hospital could deploy these, not really have to worry about the cost. They could mail them to patients, connect in a telehealth type atmosphere. So the real goal was to just bridge that divide, as Dr. Sun, sort of so perfectly said, and that's what we've really been focusing on.
I think you touched on some of this. I don't know if some of the other panelists want to jump in here in terms of responding to or adding to anything that Joe has mentioned. But Joe, what approach has your organization or your company taken in terms of ensuring equal accessibility of this particular technology? Because certainly you talk about a divide. I think Alexis or Dr. Sun did outline how a very privileged area may have better access or more access to these technologies.
Yeah, I think we start by looking at the cost structure, right? Healthcare in this country is extremely expensive. We have doctors that are well trained and well paid, and big beautiful hospitals, but the reality is there are patients who need a level of care that may not correlate well with where they are from a socioeconomic standpoint, or a sexual orientation standpoint, or a gender standpoint. And our view is that every person deserves equitable access to healthcare. We call it democratizing healthcare internally, and the goal is really just to get these devices out there. We have a very flexible cost structure in terms of we can have almost no upfront hardware cost for patients who are on Medicare or Medicaid. We can get reimbursement that can cover the entire cost on a monthly basis for these devices. So there's really no out-of-pocket cost for somebody on a consumer level. But again, our goal is to get these out there, get people using them, help clinicians and nursing and staff get accustomed to doing this, and going back to what they do, which is deliver care, right? Not ask people to wear something or touch something or remove clothing or get up or answer questions. We're all sort of this analog species, and our device is designed to really connect your personal information with all the brilliant technological things that we've enabled in the back end to help it become more ubiquitous and give people easier access to care in a more comfortable manner, whether it be in a home setting, a clinical setting, or a long-term care setting.
Ian, I know you jumped on. I'm very interested, given your background in advocacy, if you have some thoughts around accessibility or things that Joe has sort of presented in terms of your specific slant on things.
Yeah, thanks for the invite. Happy to be here. Yeah, for us here at HIMSS, we have a little bit of a struggle. I'm on the. It's not really a national. It's the global panel for public policy, and the struggle for us looking at this is you can't just focus on a specific way of healthcare delivery, right? Like our healthcare delivery is very different from Canada, and they're just neighbors as compared to Asia Pacific, compared to Europe. So what we focused on are principles, and our principles go by, the first one is interoperability. Regardless of where you are on the planet, you need to be able to connect and communicate. With that, you also need to have a secure network. So cybersecurity comes into play. And along with that, you also have equity, making sure that people have the right access at the right time. And the last one is value-based. So looking more at the value instead of fee for service, and moving more in that direction. So looking at where we're able to help you get to where you need to be, and not just do things to you, right? So in talking to leaders from around the world, and talking about how we can move healthcare in that direction, well, equity really pops out, because the future is already here. It just so happens that it's not for everyone, right? There are a lot of groups that are left behind and are still in the dark ages, so to speak. And one of the fascinating statistics that I'll share with you, I was talking to the lead scientist, data scientist in Canada for their government. And one of the things they found is that the African American group there, as well as in the United States, were hit the hardest by COVID. And if you think about it from a healthcare system perspective, it couldn't be further apart, right? One is nationalized, one isn't. One has more access, one doesn't. However, the outcomes were statistically insignificant. So we were having this long discussion, just jumping into the data and looking at, why is this? Is it just really a factor of genetics? Is this really a factor of lack of information? Is this more hesitancy to approach healthcare? So there are a lot of things when you take a look at this from a meta view, and you zoom all the way out, you can see that the equity problems are really huge. Now, zooming back into California, what we have been working on, and I'm happy to share with the group, is that one of the things that helps with equity is access, right? If the more people have access, then the more people have a chance of being part of the treatment. And in California, last year, we were able to get Gavin Newsom to sign $6 billion funding into law for broadband. And what this does, it helps provide separated out between the middle mile, the last mile, which is for homes and businesses, and also we're creating a position that will be a czar for broadband. So all of this funding will help provide more access for folks who don't currently have access, and this affects both education and healthcare. So this is something we've been fighting for 7 years now here in California, because at the end of the day, we can improve healthcare, and healthcare in the United States is amazing. If anyone is rich, sick, Vietnam, any country, the first reaction is, let's go to the United States, right? But if you're in the United States and you're part of the disenfranchised group, you're thinking, what on earth? So here I'm working with UCLA right now. A huge part of my work has been with marketing, is really to open the doors and let people know the amazing world-renowned treatment that is literally in their backyards. But if people don't know about it, right, then you know, if you don't know, you don't have, right? So you can't partake. And just to add to the chatbot conversation, have a story to share. When COVID first hit, I was pulled into to help marketing and get the word out, because we have 850,000 patients in our email listing, and with that, the chatbot capability. And we were thinking, how do we let people know what to do? And you know, healthcare, we have a tendency to overcomplicate things. These are the 31 things you need to remember, right? So we had to really narrow things down. And our guiding principle was, let's assume we're talking to a 5th grader. And let's make sure that the words that we use, the instructions we give out, are easy to understand. We use that same principle for letting them know about COVID, letting them know what to do, how to protect yourself, all of that. And then soon, once we got the ability to do testing, information about that, information about parking, information, like all the basic things, right? And as you know, people who are more in the disenfranchised group, they're the ones that struggle with these things. You know, if you don't have a car, how do you get to West Hollywood, right? Like how do you get to Wilshire? So all of these things that if you're rich or even, you know, middle class, upper middle class, you don't think about these things, right? So having someone, an advocate, a voice, someone who thinks about people who don't have a seat at the table, who don't have a voice, who can't raise their hand and say, how do I get there by bus? That has been one of the keys to our success, dare I say. So
Ian, I can't agree with you more, right? It's having those who will speak on behalf of the ones who don't have a voice. And how do we make our resources or even the use of technology easy, right? And this is great because I know Joe has some slides to share with us that kind of lead into that in terms of sometimes the adoption of technology, we make it harder for our patients and then harder for ourselves as clinicians. But how do we bring technology into a space where it's easy to use? And Joe, I know you have some slides to share to kind of, you know, provide some insights to how Nitira's solutions work that well.
Yeah, sure. I'm happy to run through them pretty quickly. You know, I think one of the things that you know, is unique about working for an Israeli company is there's really nothing that is off limits, right? If you come with a good idea and you can implement it and you can help and you can think about it differently, people don't really care where the idea came from if it's willing to help. And I think that's just a cultural difference, that Israel is willing to adopt new technologies earlier. They're willing to try things, they're willing to fail and get back up. And I think our company and the technology we came across and we developed, it really speaks to that. So I don't know how many of you can see me, but I'm going to hold up this little device here. This is what we've developed. And believe it or not, it's a sensor that's based on radar, right? So most people think that radar is, you know, tracking airplanes in the sky or ships in the ocean. But the reality is that radar is measuring changes in distance. And what we developed was a sensor that works at a very, very high frequency that measures very, very small movements. And those movements are your cardiopulmonary activity. So when you put your finger on your neck or your wrist and you feel your pulse, we're measuring that movement down to the 10th of a micron. And because it's radar, it can penetrate through your clothing. It can penetrate through the linens of a bed. It can be embedded in a chair. It can be put, you know, on a kitchen table or in a doctor's office. And we can measure right now up to 5 feet. Our next generation product up to 8 feet. You can be sitting down, lying, front or back. That data transmits over cellular signal or over Wi-Fi. It's accessible anywhere in the world from any clinician, any caregiver. And the ultimate goal is to put all that data together, understanding that different genders and different sexes and different BMIs and different age groups do have different characteristics, and they're blindly put into pools, and we can understand analytically who might be more disproportionately affected by something, or we may be able to learn from one person's ailment and help catch something earlier for somebody else. So we call them the 3Ds. It's, stressless detection, accessible data, ultimately driving informed decisions. So we think about it a little bit differently. We try to take a very unique approach, untether people from the technology, allow caregivers to share this information with somebody that might be on the other side of the world, that might have a specialty in a very small, chronic heart failure case, and allow somebody to get access to care that they may not have at their front door. That doesn't even require them to get out of their home, right? This is just using the amazing piece of technology that are there, but connecting people to that. I'll touch a little bit more on today what we're doing. So you're going to recognize a lot of the metrics here that we're capable of capturing, but you also might not recognize some, like BioID. BioID, we actually stumbled across when we were looking at the signals that our systems are capturing. And because we don't use a camera and we don't have a microphone, we had to figure out how to say, okay, this is the information from the right person that we want to put in the right electronic health record, or we want to verify that the information we're capturing isn't from a grandchild running around the house, or isn't from a niece, or isn't from somebody else. It has to be that person. So we developed this BioID, which allows, as you can see here, everybody's heart wave is a little bit different. And this is the way we verify who you are for your clinician, for your electronic health record, for your insurance company, for your hospital, so they know that you are in fact the person that they need to be. And it allows us to then say, based on these demographics or based on this outcome, what should your resting heart rate be, or what type of EKG trace should you have, or another one is, have you been moved enough in bed? Are you moving on your own? Does a nurse need to come in and move you? Are you at risk for pressure ulcers? Have you gotten up 15 times in the middle of the night to go to the bathroom? Do you have a UTI infection? And all of these things we can do without needing to touch anybody, without needing to have a camera on them, without needing a nurse to be by the bed. Now, we're not trying to get rid of nurses. We're trying to help them automate and augment their workflow so they can go back to giving care in the way they want to, not the way they've gotten accustomed to having to. Again, all of this is about removing the visual, removing the biases, and just looking at the person for who they are and what their physiological underlying conditions are. Again, BioID touched it. Is a little bit on accuracy. I'm happy to share these slides with anybody. I can share them with Alexis and her team, and she can get them out to you. But we are not, we have a very high degree of confidence in the technology we built. Our ability to understand who they are, very high confidence. Blood pressure, this is sort of the holy grail of vital sign collection from a contact-free manner. And if you think about what a blood pressure cuff does, right, is it applies pressure to your arm, and then it measures the resistance as the blood's traveling through the veins. We are actually removing the need for a cuff, and we can measure that resistance by using the pulse wave as it travels through the body. So again, there's people who have touch sensitivities. You're talking about populations like autistic people or people with Asperger's who don't like touch and don't want to be around people. We can change the way that they get a level of care because we don't need to interact with them on a bedside manner. They can be comfortable in their own home without the need to touch anybody. So these are, again, the voices of people who don't speak up for themselves. We're trying to think of how do we make this more simple. The other thing is this doesn't even have a button, right? There's no on-off switch. There's no reset button. You literally plug it into the wall. And that allows people who have motor impairments or elderly to get access to a level of care and connect with people that they might not ordinarily do. So again, we're just trying to think about it in a unique perspective, enabling care and access to people at a relatively inexpensive price, and removing all the biases and invasions of privacy and need for touch, and various things like that. So can also do things like sleep and sleep detection. We can classify it. No need to go into a sleep lab anymore. We can detect and classify all sorts of different apneas. This is a little bit about what our signal looks like. So these big waves here that you see are the respiration amplitude. This happens to be something called central apnea, where your mind essentially forgets to tell your body to breathe. And in the same waveform, you see the heart rate. And if you zoom into that heart rate, it looks like a normal EKG trace. And again, all of this contact-free, patient sleeping, doesn't even know It's really just a unique way of thinking about it, and it took us a long time to develop, but I think we're finally, COVID helped us get people to understand that we need to do more with technology instead of relying on the things that we've had. And we've had a lot of shifts in our country in particular, but around the world, with understanding different people's needs and really trying to address them at a fundamental level. And I think our technology is helping bridge that gap at the right time. So Alexis, that's all I have in terms of the tech to run through, but I'm happy to answer any specific questions that you guys may have related to it.
Yeah, absolutely. And you mentioned, potentials for home care. This could be mobile, this could be at a hospital. So I think I want to direct my next question then to Dr. Goodwin in terms of what have some of the current challenges you have been experiencing while offering your patients a sort of digital platform in order for them to access care?
So many. And again, my perspective is pretty much, oops, is my camera on? My camera is on. Good. Okay, very good. Sorry. And my perspective is really much kind of the ambulatory, again, FQHC environment, and not so much sort of the inpatient environment here, but like many other places, we suddenly found in the beginning of 2020, we need a telehealth platform and we need it like yesterday. And particularly with how the pandemic hit New York City. So we adopted it rapidly, and we've discovered many challenges sort of along the way as we've gone forward with it. And I kind of been thinking about this, put together a list here. And I think many of these would actually apply to a broad range of technologies, not even just telehealth, like so much of what had already been presented with Nitira. So and many of these I think would be no surprise. We've encountered many challenges with access to the right kind of infrastructure. So whether that is having the tablet or the phone or the laptop to be able to do a virtual visit, or the stable, reliable internet connection, which I think many of us remember early on when everyone suddenly was working from home and everyone was on Zoom or Teams at the same time, Verizon or any of the companies, I guess I shouldn't say a company, all of them were kind of stressed and challenged. The infrastructures just were not built to handle that much traffic at the time. So we found that as a challenge early on, particularly I think with platforms that utilized a lot of encryption of data that just many times we would lose audio or video. We realized trust, and not just from the patients, but I think also from many of the providers early on was a major issue. Is this connection going to be private? Is this even going to work? I've never done a telehealth appointment before. What do I need to know to be able to do it? I think even some anxiety early on. I think that's gotten a lot better over time with many people, but I would say we still have some patients who do not trust a lot of these digital platforms for care. Ease of use. And one thing I realized early on when I was involved in many of the projects to roll out telehealth, I had been caught using a phrase, tech savvy, and had corrected myself and said, that's actually a totally inappropriate phrase to use, because the problem is not the person who's not savvy enough. The problem is the technology is not user-friendly enough for everyone to be able to use it. So I gave myself a hand slap for that one. Safe spaces for conducting visits. And I would say that as, again, both on the side of the provider and the patient. We had providers who were in one-bedroom apartments with an entire family. And it's, and I have to get on a visit here and talk with you about your sexual health. That is something that could be really complicated in those situations. And similarly, I mean, I have been surprised with many patients where they seem to be totally comfortable conducting visits from like the line in the grocery store or other places, at which, that's kind of another part that we've really struggled with. How do we set appropriate boundaries? And what are those appropriate boundaries with patients for conducting for like telehealth visits, and how do we set those boundaries? How do we accommodate people in reasonable ways without really alienating them or kind of denying care that they need, but at the same time making sure that it's all happening appropriately. We've had issues where patients have shown up to visits without their clothing on. patients who are actively using or drinking during visits. Issues that like both we probably want to address, and then at the same time, we need to negotiate those boundaries. We've run into a number of issues with youth, and particularly with consent with youth. How do we maintain privacy for youth, but at the same time make sure that we're following the laws as far as minors consenting for those visits. Interstate licensing reciprocity has been a major issue. And so like these are things that all people on this call have thought about, but particularly located where we're at in New York City. And with kind of the specialized care that we do, we have a number of patients who are located in New Jersey, and it would be wonderful for them to be able to use telehealth to connect with us. And then that also means that I'm practicing in a state without a license, and we don't really want to run into any issues with that. So that one's been another kind of major pain point that we've been advocating and asking for some government support with that. I think also, early on when this all happened, please stop me if I'm speaking way too long here.
Oh, no, not at all, because you
Okay.
mentioned government support, and I know in terms of during COVID, even during these times right now, I always think about the legislative process and, how our hospitals using FCC grants that are awarded to them so that they can advance health and make a difference in their communities. I know you've been, a part of that as a recipient.
Yep, we have been. If I may, just a few more items with some of the challenges, because I know the FCC grant was another question that I had. One thing I think we're having to also kind of think about now is, again, early on in the pandemic, everything was virtual. Very little was in person. Now we have a blend. And now we're starting to run into the situation where we have to think about, well, what is really an appropriate digital kind of visit or digital a digital platform would be best for care versus when are we starting out with digital and then inviting people in person to assess what's going on? When are we creating double visits? How are we making sure that we're using these appropriately going forward? Payment parity has been a major issue as well. Again, no surprises there, but particularly with our kind of FQHC structure for how we get paid, we've really been bumping up against some issues there. We want to be able to continue to offer these services, but make sure that the reimbursement will be there. And then we've talked with many patients, and I think this is true with portals as well. It's starting to get like, all right, so I've got my account with the pharmacy and with the hospital and with you and the clinic, and it's like, can it all be one? And I would feel the same way. I would love for it to all be one. The FCC grant, Alexis, that you mentioned was so helpful for us. What we were able to do with that, the laptop I am using right now was actually purchased by an FCC grant. It was vital funding for our staff to be able to have access to the kind of technology they needed to provide the support. And partly our providers, for sure. I mean, at first when this happened, we were trying our best with like whatever Mac or PC you happen to have at home, and we hope the remote desktop will work well. That worked out okay in some ways, and in some ways that was an absolute nightmare. So getting everyone on the same system was actually really helpful just for making sure that the technology worked. But we also had a lot of staff, like our call center staff, some of our call center staff or referral staff who didn't have technology that they could be able to do work and access the EHR and work from home. So that grant saved us in being able to do these services during a really critical time.
Absolutely. Rosemary, you have any questions for Dr. Goodman?
I think he's brought up so many interesting points. I wrote so many of them down. Number one, I think it's so interesting, right, Dr. Goodman, that all of a sudden, as informaticists, we've been trying to push these technologies for so long. Telehealth's been around for the past 30 years. No one would touch it. Now you can't live without it. And so I think that it is such an interesting perspective in terms of those points that you've brought up. And yes, certainly we all had a learning curve. as we went into this, but we are in such a better place right now to continue to advocate for all of this, especially if it has become such a satisfier for our patients. I think what I'd like to do is build on that to see if, in terms of outcomes, are we there yet in terms of the research, in terms of the access, in terms of what is this demonstrated, what have we learned from it so far, in terms of really thinking about treating patients differently, especially when we've had challenges with access? Has this really made a difference? Or do we still need to put energies into the trust factor that you brought up for the patient, for even variations in patients? So is one patient population less likely to utilize this, etc.? I'm just opening it up to our panelists. I don't know, Carolyn, not to put you on the spot, Dr. Sun, but from a research perspective or even from your own experiences, does anyone have sort of a story behind or thoughts around, are we changing the culture? Are we changing outcomes?
I think it's a really important question, and it's something like we're always asking ourselves as scientists, right? Like, I think at the end of the day, I'm a nurse, but the reason I went into science and research is to ask that exact question. Like, what are we doing to improve healthcare outcomes? And so it's a really tough question, and I don't know. And I'm literally doing studies on it right now. Are we making a difference? Like, does telehealth make a difference? Does it make a difference for like underserved populations? I hope so. It's something I really want to say yes. Oh, it's amazing. We're doing a great job, but I just don't know. And I think it's something we're all working on. I think there's been a lot of research on it. I think it's something that we need to continue to like delve into, like, really, does it make a difference? And honestly, like, I don't know. I feel like a lot of us live in New York City. I myself, my closest friends, we can't get a healthcare appointment to save our lives. Like, and mental health, even harder. It's so ridiculous. It's devastating personally, for my friends, my family, all of us. And I hope it is making a difference. And I really think, like, in some ways the pandemic has done us a service in opening and making healthcare more accessible. But then, like, a lot of my research is global stuff. So like in Malawi, where they don't have internet, like the average per capita income is like $110 per year. Like, how do they access healthcare? And what are we doing? I don't know. So I don't know. It's a great question, Rosemary. I hope we can answer it. And I would love to like continue down this path of like, what can we do? What are we doing? Is it making a difference? But I can't like definitively answer it, and I don't even want to try because I don't want to be like an arrogant person who says something more than they know. I don't know. That's the answer. But
that's true for a lot of areas. So, you know, it's not just this, but I think it is a question for folks that are in positions or in these positions. And it's just good to know that you're not alone, Dr. Sun. We're asking this every single day. It's just a matter of then putting the right resources into these spaces so we can get funding to do that research. I think is an important point that's come out of at least this discussion. Any other thoughts on some of what I think? I did know that Dr. Goodwin had put up his hand, but I see Ian's putting up his hand, so I'm opening it up to you guys.
I'll yield the floor to Dr. Goodwin, to the distinguished gentleman in blue.
Oh my goodness, thank you. But would be happy to yield the floor as well, since I just talked a bunch. I mean, I would have to say, part of it I feel like is there's a parallel with like remote work, and that now, you know, offices are opening back up again. Employers are trying to get people to come back into the office, and a lot of employees are saying, no, I'm not. That's, you know, this works just fine doing this from home. And I think there are some parallels in healthcare and healthcare delivery. Many people who have tried it and have now said this is how I want to continue to receive at least part of my healthcare from now on. So I think there's a piece of it that will be around for a long time. And I've thought quite a bit, sort of Dr. Sun alluded to, like there's potential to worsen disparities, absolutely, with some of these challenges. But I can also say anecdotally, and I realize to a scientist, anecdote is like, la, 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 I didn't hear it. Anecdotally, there are people that I've been able to reach through telehealth that I was really struggling to reach when the only care I was offering was in person. So I think even if it doesn't, you know, even if we struggle to still find ways to engage certain communities, even if the systems we design still have barriers for certain communities, there are some that this has been the answer for, and that's encouraging to me.
Ian, did you want to make a comment?
Yeah, I know that the jury is still out on the outcomes, you know, quantitatively, but I have to say that, you know, in healthcare, all outcomes start with a conversation. Change starts with conversations. Change starts when there's a new paradigm. Change starts when there's a new idea that's being shared, that's being tossed around, that's being grappled with. And the more that you can have these conversations, the more that you can provide ease of access to talk to people about these conversations, you're just opening more doors for change. And outcomes follow after you see behavior modification, after you see access to treatment, after you see more modalities being in play. So all of this ties into the ability to have a conversation. And one of the things that I'm working on right now, and I started the conversation in Dubai, was how can we leverage the metaverse for mental health? There's so much in the metaverse that allows for people to express themselves in ways that they couldn't do in the physical universe. And what's fascinating is I've been talking to a lot of leading psychiatrists. I've been talking to gamers, been talking to tech companies and also VCs. And they all said, finally, something that the metaverse can actually be useful for. They're really excited. There's a lot of excitement out there. And I'll give you a use case that really really got to me. There was this gentleman from Oman that came up to me after my talk, and he was crying. And he said, Ian, you don't understand. In this part of the world, mental health isn't just something that we're grappling with. Mental health doesn't exist. He said that if you have 3 kids and all of a sudden your kid is diagnosed with mental health, now you have 2 kids, they banish you. And I as you know, I'm usually never out of words. I couldn't say anything, and I said, I'm really sorry. From one father to another, I am really sorry, because I could not imagine my kid not having the resources in the entire country, not UCLA, not my county, not my district, in the entire country. And so he said, can I give you $100 to help you get this metaverse thing that you were talking about going? Because if my son had the ability to connect with people with cerebral palsy, perhaps he would be able to enjoy his life better. He's a 6-year-old. Perhaps he might be able to smile with other kids. Perhaps he might be able to feel the sense of belonging that you and I feel because we're able to walk around and enjoy our surroundings. So here's $100. Please do what you're talking about. It's a grown man that was crying in front of me in the middle of the hall. And so connection and the ability to talk, communicate, connect, I think it's the beginning of a lot of beautiful things. And although we don't have the quantitative data to show how good this has been, I guarantee you the absence thereof is definitely bad.
And Ian, you talk about connection, right? Mental health. As of lately, we have witnessed within our own communities, some close to home in Buffalo, in Uvalde, in Oklahoma, violence within our communities, schools and hospitals, right? And then during the pandemic here in New York, we even lost one of our very own physicians, Dr. Lorna Breen, right, to mental health conditions. And recently, the Dr. Lorna Breen Act was passed, and it's an act that will provide federal funding for mental health education and awareness campaigns aimed at protecting the well-being of our healthcare workers. So, this is a question to everyone is, how have you been able to provide care to your community, to your patients, to your staff during times of tragedy like this? Dr. Goodman, Dr. Sun, anyone?
I'll let other people talk. Nick knows I can run my mouth for hours, so
Because,
I will stop.
Is it telemedicine? Is it crisis centers? Everyone is impacted, whether it's children, whether it's healthcare workers, whether it's the community that we serve, right, to give them services.
I'll just say I teach at Hunter College and I teach graduate nurses. So there are nurses who are currently practicing and they're going back to school to become nurse practitioners or whatever. And during the pandemic, honestly, like our classes were like group therapy because these are nurses who practice all over New York City. They were like frontline healthcare providers. They were so distraught and their stories were so powerful. And we would just have these times of bonding where like there's like a nurse from Sloan Kettering, a nurse from NYU, a nurse at the Allen Hospital for New York Presbyterian, a nurse in Brooklyn, a nurse in Queens. And we would just get together and just talk about like, what has it been like for you? And I think, so for me, just like being I'm like a professor, so I wasn't doing anything myself. I can't take any credit, did nothing, but I just asked them like, how are you feeling? What are you going through? And that time was like so therapeutic for all of us. It was just like nurses on the front line telling us about their experience, about their disappointments, about their hopes and their, like their families and how they felt exposed and how they felt like they were providing and they were providing for their, their patients, but they were also, some of them were so sad, like they had to isolate from their families, like their mothers and their fathers and their kids and their grandkids or whatever. So I don't know. So I don't know if that answers your question, but like that was my experience, was like we were like a team. Nurses are a team. We were all in it together and we were just listening to each other and supporting each other through a terrible time.
Thank you for sharing that. I mean, during the, height of the pandemic up until now, I think we become very resourceful with how we treat each other, with how we treat our community, our fellow colleagues, our coworkers, children. So I think it's important to realize, what is the current state in terms of what do we have now that we can utilize in order to take care of each other. what is the future state of solutions that we can use and adopt so that we can use it, you know, to help with these issues that are coming as a result from these tragedies that are happening.
And I was just going to add, I mean, I completely agree with you, Dr. Sun. The camaraderie at times has been probably the only thing it felt like many of us had to get through so many of these moments. And it feels like our coping mechanisms also need to evolve and continue to grow. You know, I think particularly you've spoken about you know, some of the mass shootings in particular that have happened, and it seems like every time, you know, there's an email that goes out, and while it is appreciated, it's also, once it becomes, unfortunately, the nth time that you've encountered, and you know, so many of these situations at macro and micro levels, it feels like a lot of folks start to really become numb, and so that is part of the challenge too, is continuing to evolve those coping mechanisms and the tools that we have to help folks get through.
Alexis, I'll share something that I usually don't do. I found myself being a line producer for a nursing annual report for UCLA, and we got the opportunity to photograph, you know, hundreds of nurses at work and talking to patients and family members. And one of the things that we did was, as I enter a room, I would say, all right, and this is true, that the photographer I had was truly a Julia Roberts photographer. Like, she done shots for her for 3-4 times, and he actually was at the Academy Awards the night before. So I said, all right, guys, I know we were all brought here for different reasons, but for the next 15 minutes, you're going to be the star. We're going to be taking photos, we'll be sharing it with the community to celebrate not just nurses and clinicians, but also you, the patients, the family members. And part of that is we just want to get pictures that shows a side of you that is not just the patient, side of you that's not just a family member taking care of someone. And also for the nurses, a side of you that is just not just a clinician, but you, you know, the funny, you know, avid runner, whatever it is that you do, and just capture that. And we did that for an entire week, and we had, you know, hundreds of hours of footage and coverages. But throughout this encounter, we've had people laugh, we had people cry, we had people hug us, we had people, they were just thankful that for 15 minutes, they were able to forget why they were there. For 15 minutes, the nurse, the patient, the family, we were all just connecting as humans. For 15 minutes, we all got to collectively laugh out loud. And it changed everything. And one of the nurse directors came up to me and said, hey, Ian, you know, these nurses, they're not in the main hospital, and sometimes they're left out. Is there anything that you can do for them to feel that, oh, they're also kind of seen? And so what I did is I called down all the nurses and had them line up by this beautiful facade, this building. And one by one, I told them, okay, we're going to do a glam shot for each and every one of you. Just line up. Josh is going to treat all of you like Julia Roberts. Go. And for 30 seconds, we're just going through all of them. And it was such a sigh of relief. And you can feel the stress, that tension, that negative energy just leaving, you know, the nurses collectively. And they all went back. They were glowing a bit more, you know, had more blood in their cheeks. They just were able to collectively take a deep breath and exhale. So I think we forget the simple things that we can do to connect, the simple things that we can do to break that divide, the simple things we can do to show that, you know, even though there's a lot that, you know, separates us, there's also a lot that binds us. And if you can bridge that gap, you know, putting technology aside, you as a person right now, after this call, there's so much that you can do to pull people together. So I encourage you to look for those simple things as we're talking about, telemedicine, broadband, and all of the big technology things. You can make a difference right now, and it doesn't need much. Just a conversation that starts it all.
Yeah, absolutely spot on with that, right? It's the advocacy and the connectivity of just the human aspects of things, right? Everyone can be sad, can be angry, can have their feelings. They're all working. They're all clinicians, for the better good of the mission of what they're there to do, right? Thank you for sharing that. That's really, really, really poignant. That's really great. Dr. Sun, I know you mentioned Malawi, right? And I always think about, we talk, like what Ian was saying, we talk about solutions, we talk about technology, broadband, securities, all of those. But what can we do to make sure that no one's left behind as we welcome all this technology? What about those places that are in rural America, like what Joe was mentioning, how they provided, services to those areas? I've driven across the Appalachian Mountains and, sometimes service is not available. And you mentioned Malawi. What can we do to ensure that that community is also served?
That is a tough question because honestly, so during the pandemic, I did a webinar with colleagues in Oman, which Ian mentioned, and Uganda, and just talking about what is it like for nurses. But my personal experience is it's hard to get funding from the US government to do anything for people in other countries because we don't, as a country, we don't want to fund anything that doesn't benefit us personally. And in the Appalachian, I actually grew up in West Virginia. So it's near and dear to my heart. It's something I would love to do, but it's hard. It's hard to get funding. So I think one of the things that we could do would be just to advocate for funding for these underserved populations, people who, I don't want to say I don't know how to say it, in terms of our government, they're people who don't matter. In terms of who we think matter, they're people, they matter to us and they're very dear to our hearts. So I think there has to be, and I know this is outside the scope of research or medicine or whatever, but I think there has to be some advocacy for these populations who are underserved and underrepresented, and there's no funding for research because a lot of the research I've done has been just white papers for people to build their, because it's for example, some of the first work I did was for populations in African countries, and it was hard for them to get funding for the research that they wanted to do as nurses in Africa because nobody cares about them. And so if they don't have any research to write their grants and say look, there's a deficit of research in this area, then it's hard for them to get funding. So a lot of the work that I have done has been trying to build this foundational white papers so that they can get research to do the things they want to do to care for the people that they actually care for. It's just hard. It's a very difficult situation because we don't, as a nation, we don't care about people if it doesn't benefit us. And I think that I going back to that presentation I gave earlier, it's part of that critical race theory that there's this convergence theory. We're not going to go out of our way to help people until it causes some kind of a problem for us. And nobody likes to hear that. And I know that. I know so well. I feel like the stuff I say makes people so angry, and I don't even understand why, because I'm just stating facts. But yeah, that's what I think.
What you're stating are things that we need to hear, and when you get a reaction, that just proves that's why it means so much, right? Like, why should we care about health equity? Right? I mean,
right. I mean, we should care about it because it affects all of us collectively. But I feel like until we have these like research papers and scientific documents saying like, this is a big deal, we need to care about it, our government is not going to give us research funds to do stuff. And that's really troubling because we need to help people. I don't know.
We talk so much about advocacy, right, Alexis? That's the whole group that Mary Joy has put together here in HIMSS, is how do we advocate in these specific situations. But I think one of the things if in terms of advocacy that I have found difficult, and I wonder, like Dr. Goodman, if you've noticed this or others, is that bringing it back to what Ian mentioned about conversation. One of the most challenging things in my own work here is having nurses ask questions about social determinants of health, even screening patients about, do you have enough food? Can you get to your appointment? They are so uncomfortable because I don't think we have given them the tools to have those conversations yet, because they don't even understand what the impact of those inequities mean on healthcare. Why do I care about that right now? The patient's in here for CHF. He's already here. It doesn't matter to me if he couldn't get here by his own means or by ambulance. So how do we demonstrate? What do we teach people? What do we, give them in terms of tools to have these discussions? Interested in what the panel thinks about that.
I have a story, Rosemary. I'm the opposite of Carolyn. I have no data whatsoever, just stories. So I was helping a cancer center rebuild itself from the ground up. And my focus was on the outpatient center. And one of the things that I focused on was the no-shows, right? And especially for cancer patients, no-show is life-threatening. Right? This isn't just a cold. So I started to dig deeper, and when I started asking around, the nurses didn't really have a good answer. Like, why is, Betty Smith not showing up? Or why is, Tom not here? It's Tuesday, 9 o'clock. What's going on? And lo and behold, I did a lot of digging, did a lot of digging, and a lot of it was related to transportation. A lot of it was related to the fact that these patients were more than 65 years old. They couldn't drive anymore. And a lot of it was dependent on the availability of either their child or their in-laws. And guess what? All of them were working. So what we did was we found a way to allow for taxi services to pick them up. This was before Uber and Lyft and all of those guys. And we drastically dropped the no-shows, because guess what? Cancer patients want to show up for their chemotherapy, right? But if there's no one there to drop them off, they're also not the type to keep bugging and picking up the phone and calling who else can drop me off, because they're also kind of embarrassed and ashamed. They don't want to bother people, right? So what I did when helping with the cancer center and address this with the nurses is we talked about the end in mind. Our goal isn't just to give chemotherapy. Our goal is to help the patient get from here to there. And in doing that, in getting to the end state, which is hopefully a healthy, longer life, These are the steps that we need to do. Chemotherapy just so happens to be one of them. So if you think about it with the end in mind, then what you'll find is that nurses are very resourceful and creative. But if you just focus on the treatment plan in front of you, well, I can't start it if the patient's not here, right? But if you broaden the scope, broaden the conversation, and look at it with the end in mind, then it changes the perspective of things. And then what we've noticed too, just continuing with this story, is that we were lumping in patients who were just there for a 30-minute appointment with someone who needed like a 4-hour treatment. So now they're waiting in line, waiting for another chair, waiting 4 hours for something. They just need 30 minutes. So we created what's called a fast track. Anyone that had a less than an hour treatment, you're in this line, right? And lo and behold, without adding extra nurses, we were able to add 28% more capacity, more throughput, just by making that small change. And this wasn't rocket science. My approach is just asking things like a 5th grader. Why is this happening? Why is grandma here for 4 hours when she was just here for a shot? Well, why? Just keep asking the whys till someone gets really pissed off and just starts answering you so you'd go away. And what happened here was a 28% increase in their throughput. So when you provide a different context for clinicians, when you change the conversation again, then the resourcefulness of nurses starts to come out. So that's what I encourage folks here. I'd like to advocate for better conversations and try to just, if you change the questions, you also change the answers. So I hope that this provides some context.
No, that's great. I know.
Can I just
yeah,
add
sure.
to that?
Absolutely.
Yeah, I think at a fundamental level too, when nurses are in the process of their daily work, they sort of get wrapped up in, running from one thing to another without sort of thinking holistically about the problem. And our take on this is, if you can alleviate those mundane tasks and allow people to connect with patients at the fundamental human level and have time to ask those questions and have time to get to know patients at a personal level, you kind of reframe the work that a nurse is doing, and you allow them to get back in touch with the patient and think about it in a different perspective. So just, food for thought.
No, that's a great point, right? Like, how do our solutions give back time to our clinicians to actually do the work, to do the healing, to do the focusing on their patients, right? The original mission of what we're here to do. Great point.
Yep.
I know that I like to be on time. We have about 5 minutes or so, and I want to give opportunity to our audience and like for a QA. Christina, are there any questions that you wanted to ask that you noted during our time?
Hi. Well, thank you everyone for sharing your knowledge and engaging in this important dialogue. I see that we do have an audience question from Matt Bishop directed at Joe Zaccaria, wondering about how long has the safety of exposure to the radar at Nitira in close proximity to patients been studied?
Yeah, good question. We get this all the time. It just sort of comes with the territory of doing things differently. Quite a bit. So we have FCC and ECC certification. Our device emits 1/10 the power of a Bluetooth headset. So you could sit next to this for hours and hours and hours on end, and you'd have no issues. We've done work in neonatology units with very fragile skin. I don't want to get too deep into the technology, but the frequency at which our device operates at, it refracts off of your skin with a certain water density. So there's actually no penetration of the signal into the skin, which is why we get such good resolution, but there's also no safety concerns. So good question. We have all the documentation to back it up as well.
Great. And I know someone mentioned about slide sharing, Dr. Sun, Joe, or is that okay so that we can share with our audience members?
Yep.
Of course, you can share. I mean, the stuff I presented is all other people's work that I have cited, so you're welcome to all of it. Thank you.
It's all important work, all important work. And then any other questions, either from our group, audience, or anyone for anyone?
I was just gonna say in regards to like nurses and like Joe was talking about, you know, whether they are doing what they're tasked to do or whatever. I can speak myself, and I'm sure a lot of people can speak as a nurse. Like, you want to be like, the reason we join healthcare is because we care about people. That's the whole reason I'm there. And the fact that like the patient ratios make it impossible for me to do all the work that I want to do, or like just like a small issue amongst all of the reasons that we need to like really look into like healthcare staffing and like, what are we doing? Why do we have nurses staffed at these insane ratios? Like, one of my students the other day told me there were 18 patients per nurse. I don't know. I'm from the West Coast. Like, that is not a thing that happens in Washington State, California, Oregon, like none of those. And I was like, that's crazy. I don't even know. Because even when I was working at UCSF and I was on day shift and I would have 5 patients and they were like the highest acuity patients in the state because it's UCSF and that's where all the best care happens. I struggled. Like, if I had a patient with 25 medications and I had 5 of them, and like we would wear a pedometer, we'd track how far we would walk during a shift. It was like 13 miles per shift just in the hospital to take care of our patients. I don't know, like, we can't blame nurses for like not doing their job when we're giving them these expectations that are so crazy. Every day I felt like all I want to do is like brush my patients' teeth, give them a bed bath, like help them change their sheets. I don't have time for any of that. Like, if I'm lucky, I'm gonna give them their 25 medications, their IV fluids, their, you know, whatever. Anyway.
Absolutely, right? It's back to what Joe was saying, where
Yeah.
the technology we bring should be easy. It should remove the mundane tasks or, you know, the ones that have taken up most of our time. Then it allows us, like what Ian said, to have these conversations back at a human level. So then that way we can have, you know, care provided to everyone within our community. So this is fantastic. And, you know, I really just want to thank everyone for participating. And then, so I have here Tony Ferrante, who is our president of the New York State chapter, for some closing remarks.
Thank you very much, Alexis. And I'd like to say thank you to both the Adversity and the Advocacy Committee for putting on a great event. Rosemary, another great job again moderating this panel and helping them share all of their great ideas, and we really appreciate that. Keep your eyes open, everybody, for our next events coming up. We have one for mental health and behavioral health will be coming up pretty soon. And for those that have registered for our election process, we have our election coming up. So we're looking to bring on a couple of new members. And listen, we became the large chapter of the year due to our members and our committees. So if you're interested, please join our chapter. And it's real easy to happen. Everybody have a great evening. Thank you all for participating. This recording will be posted up on our YouTube page as well as onto our website. So for those that had to leave early or couldn't make it tonight, you'll be able to hear the great presentations by all of our speakers. And again, thank you to all of our speakers. Great job today. Appreciate it.
Tony, thank you.
Thank
You're
you so
welcome.
much, everyone. Thank you.
Good
Have a
night.
good night.
Good night, everybody.
Right, thanks.